Yeah, so I'm very happy to be part of this session. This is, I've heard the earlier talks, and this session has been really helpful and good. Thank you for this. Let me invite the first speaker, Dr. Dinesh Jyothimani. He's a director of hepatology at Rela Institute of Medical Center at Chennai, and he's going to speak on immunosuppression in combined liver and kidney transplant. Over to you.
Yeah, thanks, Ravi. And it's been a really wonderful meeting and brilliant discussions, all practical stuff. So I'm just going to share the screen. So today I'm going to talk on immunosuppression in patients with combined liver kidney transplantation. I mean, the previous session was actually paved the way for this talk, actually, because it was nice discussion on how to manage kidneys in the postoperative period. And, because as a hepatologist, I think we are getting better and better managing the kidneys as well as the liver, actually. So today we're going to discuss about how immunosuppression we can tweak in patients with combined liver kidney transplantation for the better survival. But let's give a background, actually. So what are the indications for combined liver kidney transplantation? Currently, it's a changing sort of indications right now, but what it was 15 years ago, it's slightly different now. But the recent ones are in the presence of acute kidney injury, if the patient is on dialysis for more than 6 weeks and then they require combined liver kidney transplantation. Whereas in patients with chronic kidney disease, if the GFR is less than 40, and also if they have sort of other risk factors, it's better to go ahead with combined liver kidney transplantation. For example, in patients with CKD with GFR more than 40, we can preserve the kidneys and try and manage with liver transplant alone. So, but as we say, this is a changing indications, but there are other fixed indications such as primary hyperoxaluria, where you end up having a combined liver kidney transplantation. Now, I mean, this slide, you probably have seen the whole session today, how the immunosuppression works. So there are different immunosuppressions we use on the induction agents, which are very specific to the receptors. And then we have tacrolimus and the cyclosporine, and then Everolimus, sirolimus, which works on the mTOR pathway, and anti-metabolic drugs. So which we heard this the whole day, actually. And these drugs are used in various combinations to protect the liver and the kidney. And as hepatologists, we have more experience in managing liver patients with use of these drugs. Now, what is important is, if you look at this study here, the long-term analysis of combined liver kidney transplantation, most of the studies are single-center experience. And this from 1988 to sort of 2002, actually. If you look at it over a period of time, there was a change in immunosuppression from cyclosporine as a type in combination to tacrolimus, and then to tacrolimus along with MMF, and then the use of monoclonal antibodies. If you see over a period of this sort of years from 1988, there's been good reduction in the number of acute cellular rejection in the liver. But when it comes to kidney, yes, there has been a reduction, but again, it's not probably that much, probably not as good as the liver. So with changes in immunosuppression over a period, the liver rejection improved greatly than the liver rejection. And not only that, the earlier studies which have been published on combined liver kidney transplantation, again, see, before 1995, they used mainly combination with cyclosporine, azacitidine, and prednisolone. After 1995, it's mainly tacrolimus and prednisolone. So if you look at it, particularly the one from the UNOS database, the 5-year renal graft survival is still not that great, actually. So the earlier studies revealed that lower kidney graft survival in comparison to the liver graft survival in patients who undergo combined liver kidney transplantation. And this is despite maintaining slightly higher immunosuppressive levels in these patients. And also, not only that, recently studies also show that there is up to 50% of patients who undergo combined liver kidney transplantation have a delayed graft function of the kidney, up to 50% of patients. And if you look at the studies, they've used almost all immunosuppressive agents, like including the induction ones, hydrocortisone, basiliximab, and in the post-op period, they received triple immunosuppressive regimen. So despite that, there's been a high amount of increased number of patients who have delayed renal graft function following combined liver kidney transplantation. And this again, not only sort of the survival and the delayed graft function, also there is reduced renal function in adult patients in comparison to comparison to pediatric population over a period of 5 years. So you can see that the median estimated EGFR reduced from 74 to 56 over 5 years time in adults, but that pattern was not seen that much in children actually. And once again, most of these patients received triple immunosuppression. So the question is, are we doing the right things here to protect the kidney as well as the liver? I think the liver, we are okay with that, but are we doing the right things for the kidney? Are the immunosuppression correct? So previously, several centers used higher immunosuppressing agents, particularly in combined liver kidney transplantation. But with experience, there has been changes in the pattern how we handle these patients, and particularly with respect to their immunosuppressive drugs. And what we all know very familiar is about the adverse events of immunosuppressive medications. Corticosteroids can cause type 2 diabetes, systemic hypertension, and tacrolimus, very well we know it causes diabetes and hypertension. And Everolimus, sirolimus groups causes hyperlipidemia. So, these sort of immunosuppressive drugs causes a lot of syndrome that is in favor of metabolic syndrome. And this metabolic syndrome can also affect your renal function over a period of time. And particularly with tacrolimus, tacrolimus has a lot of renal side effects, and which we discussed been in the discussion in the last session. And also it is a risk factor for diabetes and as well as hyperlipidemia and hypertension. So there are a number of effects tacrolimus can cause on the kidneys. The initial acute CNS nephrotoxicity and the chronic ones. Acute is mostly sort of reversible and is related to the afferent arteriolar vasoconstriction. As Dharmesh said, it occurs in almost every patient in terms of you don't have to be a patient to undergo to develop the arteriolar vasoconstriction. However, the chronic CNS nephrotoxicity is associated with more of tubular atrophy, interstitial fibrosis, and and that causes more of an arteriolar thickening actually. So this causes chronic kidney disease. So the question is, why the renal graft function sort of deteriorates over a period of time? Is it because of the rejection, or is it because of the medications what we're using? That's what we need to know. Now, we also know that NASH is increasing all over the world, and that's an indication for transplantation. And the recent UNOS database also showed that NASH is also the increasing indication for combined liver kidney transplantation in the USA. And interestingly, they looked at the 5-year graft survival. If you look at NASH patients, they have a poor kidney survival when compared to non-NASH patients. So there is something more to this. So it's not just reduction in the EGFR and deterioration of renal function. So the question is, are we handling these patients properly? Are we addressing their metabolic risk factors? Are we optimizing their immunosuppression? And we know that NASH patients have high-risk metabolic features, but when it comes to other liver diseases such as hepatitis C, they also have metabolic risk factors, as well as in patients with alcoholic liver disease. So I think most of the world population have some features of metabolic syndrome, and this can have an impact on patients undergoing combined liver kidney transplantation, particularly on the kidneys. So the combination of higher dose immunosuppression and the metabolic risk factors may have an impact on the kidneys, actually, in the renal graft. What we know from the past is the immunoprotective effect of liver on the kidney, particularly if they receive the kidney and the liver from the same donor. So this study shows that there is more rejection in more rejection of kidney after liver transplantation if they undergo the kidney transplantation after liver transplantation compared to combined liver kidney transplantation from the same donor. So so we have on one side metabolic syndrome, we are using high immunosuppression. On the other hand, in combined liver kidney patients, we have the immunoprotection of the liver on the kidney. So we have to keep that balance somewhere in the middle, actually. When it comes to immunosuppression, even though tacrolimus may be a bad guy, as Dinesh said, but it's one of the essential drugs that we cannot give a miss. And most centers use tacrolimus as a baseline, whether it's a standard dose or a lower dose, because there are studies to show that tacrolimus-free regimen or very when you use mTOR inhibitor instead of tacrolimus, they're associated with biopsy-proven liver rejections. So tacrolimus is an essential drug. We have to use it either in the low dose at all. Now, the other thing is when you add Everolimus to with low dose tacrolimus, and this has been shown to protect the kidney a little bit, which was statistically significant. But again, we need to, its effect of low dose tacrolimus rather than the effect of Everolimus. That's what I would think from the study, actually, because standard dose tacrolimus can cause reduction in GFR over a period of a few years. So it's better to use low dose tacrolimus. And similar studies also showed that low dose MMF also has, low dose tacrolimus plus MMF has a better effects on the kidneys, and also they have effect on the arterial hypertension and reduction in the diabetes. So what is the ideal regimen for immunosuppressive regimen for patients undergoing combined liver kidney transplantation? It's clearly not established, but what I read and what we do is just to keep them on the lower side of the immunosuppression, immunosuppressive protocol, use combination of drugs to keep the tacrolimus on the lower side. But I know our renal guys won't be happy with that. They usually use steroids for quite a long time. And again, that has a lot of side effects on the kidneys in terms of the diabetes and hypertension. So avoiding tacrolimus and or the CNI is not a good idea, but certainly to keep it as the lowest dose and mixing with other immunosuppressive drugs like mTOR inhibitors or the anti-metabolites, probably it's a better idea. So the strategy is to reduce the renal impairment over a period of time. And also there's been recent studies on induction therapy, which showed reduced improved renal function in patients with the combined liver kidney transplantation. So it's a combination of all immunosuppressive drugs. At smaller doses is probably a better idea than giving a single drug at a higher dose. Except in this situation where combined liver kidney transplant patients with preformed antibodies, if they have preformed antibodies, they are prone for antibody-mediated rejection. So these patients received as a standard protocol as an induction immunosuppressive agent, and they've been maintained on higher immunosuppressive drugs. So if this is once again to show that the liver protects against the kidney if you receive from the same donor. So in this study, they look at renal transplant alone with the donor-specific antibody. They have poor patient survival. Whereas if you have combined liver kidney transplantation with PDSA, it's from the same donor, you have a better survival, and the best survival would be without the donor-specific antibody. So in patients who have donor-specific antibodies, it's better to use slightly higher immunosuppression, and also to anticipate antibody-mediated rejection of the kidney. So this recent study publication from King's College, where they used higher immunosuppressive drugs in those who have donor-specific antibodies, and if they have MFI more than 10,000. And these are the patients who are high risk of AMR, and these patients receive slightly higher immunosuppressive medications. Otherwise, the immunosuppressive protocol has been changed to on the lower side, lower dose of tacrolimus, either with MMF or Everolimus, and some centers still use prednisolone. So it's a change in protocol over the period of time, more by the experience. So, ladies and gentlemen, Chairman, I would like to conclude that although there is no definitive immunosuppressive protocol established for combined liver kidney transplant patients, Most of the weightage of immunosuppression depends on the renal graft function because the liver is more of immune protogenic, whereas the kidneys are. And preferable will be some lower tacrolimus trough level, either with Everolimus or MMF. However, those with high risk of rejection, that is, those have predisposition for AMR, may require higher immunosuppressive agent. Thank you.
Yeah, thank you for the excellent talk, Dr. Dinesh. So quickly, one question. So, when we do a disease donor transplant, we generally do not look for the donor-specific antibodies in the recipient. So should we start doing that based on the study you quoted? Second question is, as we know that there are differences in the risk of rejection, kidney rejection, between if two organs are coming from the same donor versus two different donors. So do you think that we should have different immunosuppressive protocols for combined or kidney after liver transplant?
Yeah, I mean, first thing is with regards to, see, the number of patients undergoing combined liver kidney transplantation in any single center is still sort of very less, actually. So to do, and in terms of availability of cadaver, and to do PDSA may not be feasible or practically feasible, although it's an ideal situation. But we need to have more organized system for the disease donor transplantation, where we can actually do it in any center, and even the donor hospital should be able to offer this. I think that's very important. But right now, I don't think it's feasible, but certainly we should aim for that. The second question is, should we have a separate protocol for immunosuppression between the same and the different donor? I think yes, in a way, but it depends on how the kidney function behaves. And most of the renal graft function is managed by the nephrologist. I suppose that's how it is in most centers, I suppose, managed by nephrologists. I think we just have to work in sort of close proximity just to see, we can optimize the immunosuppression properly, because I have feeling nephrologists use high immunosuppression.
Dr. Gupta, Dr. Rastogi.
Yeah, in our unit, for the policy for combined liver and kidney has been that they should get liver-based immunosuppression, and that has served us well without rejection from. But perhaps maybe our nephrologists and kidney transplant surgeons have, more friendly. But that's the policy we followed for many years now, and it seems to do quite well. The question that I wanted to ask to everyone, the panel here, we know, as I said, we do a lot of this sequential business. That means somebody, who had altered liver function, do the kidney first. And sometimes the same donor comes forward for donation for the kidney. And many of these patients, after a while, will have preformed antibodies. They don't have any evidence of liver rejection. So what should you do? Should you reject that donor, or what should you do? And I'm not clear, because this completely goes in the hand of the nephrologist. And I try and convince them that, the liver is well accepted from this donor. There should not be rejection. But there seems to be a lot of disagreement, and the patients suffer a lot. So I don't know the answer to that. So maybe perhaps everyone here, all the sort of, could debate on this, or maybe tell us what we should do.
Can I take that? So I think you're absolutely right. If you are doing a simultaneous liver kidney transplant, the immunosuppression should be based on the liver and not on the kidney. So that is the first thing to say. And if you are getting the same donor back, and you find that in a given recipient, you now have the donor specific antibodies, we must all remember that as time passes by from liver transplantation, you get donor specific antibodies. So there are two kinds, which are preformed and the ones which appear later on, which is in a sense because of lowering of immunosuppression. And once the patient gets a new organ, again the immunosuppression is going to be hiked. So it really isn't of much consequence. Unless you get very high MFIs, then only there is a reason to be cautious. But otherwise, in most instances, one would not even look for this test. So everyone who undergoes a solid organ transplant over a period of time will develop the donor specific antibodies, because the general practice is to lower immunosuppression, and that is the right practice. So that is why the AMR thing is also clouded. Not everybody believes that it exists in the setting of liver transplant. So I don't think we are well within our rights to reject this donor.
Oh, that's very nice. Very, Ramesh, I really like you.
Thank you.
A very quick basic question, if I may. Very basic question, if I may ask. I wanted to, how often are you doing simultaneous liver kidney transplants in the living donor situation? When a living donor liver transplantation, generally it is considered something that you would do for in a deceased donor setting. So maybe you could tell us, Dr. Jyothimani.
In a living donor setting, I think, right now, maybe we may not be doing big numbers in adults. In pediatrics, yes. But over a period of probably in the next 20 years, when NASH and you're going to see a lot of diabetic population, chronic kidney disease, I think there will be increase in combined liver kidney transplantation over the next decade, I'm hoping so, because of the risk factors that we are facing for a period of time. But in general, probably I would say combined liver kidney, I can't quote a number, but not much in adults. Yeah. But over a period of
the simultaneous liver kidney population also needs to be divided, sir. It's not a homogeneous cohort. So those who get transplanted, for example, somebody who underwent a liver transplant has now started to develop chronic kidney disease. He's different from someone who's got diabetes and he's got NASH cirrhosis as well as diabetic nephropathy and probably impending renal replacement therapy. So at least in our program, we would need 2 donors. We do not take the liver and kidney from the same donor. So that defeats the very purpose of doing a simultaneous transplant. However, we are also a busy deceased donor program. And therefore, if you have a chance to do a simultaneous liver kidney, you would want to do it the deceased donor way. So that is what we do in our practice. So we don't take the 2 organs from the same donor.
Most patients
sequentially they can donate. So what Dr. Subhash was saying was a different thing. So sequentially they can donate. So this person who's donated once, some years down the line, can come back to donate the kidney.
So,
but we would not take both
two living donors for one recipient at the same time. Is that commonly done?
No, not at all. So you should try to have such a situation not occurring. That's what I said. So deceased donor. And I think we should...
most patients with liver cirrhosis and kidney disease, usually the liver is stable. It's the kidneys that are mainly.
I would like to share our thoughts on this.
One last comment from Dr. Subhash, please.
We do a lot of this because we have a very robust kidney program, and quite often they have a patient who's scheduled for kidney transplantation, and then they find they have ascites. And they are very, very reluctant to do a sort of kidney transplant these patients. We end up doing many patients like this throughout the year. And in fact, right now also we have a person on the ward who has absolutely no liver disease, but the kidney guys, they've done a HPPG is high, and they will not consider kidney alone in them. So we do a fair number of that actually. And they don't have any liver symptoms apart from ascites, which, in the past I used to think is a feature of liver disease, but of kidney disease. But they think no, if the ascites is there, that means they have
HPPG is high.
Yeah, I think that's very the standard recommendation, HPPG high. So that's probably followed. Maybe this also needs to be looked into further.